Hi everyone, I'm wanting to make sure we're recording. Dave, just confirming from you that you are recording, so I see the red light. Hi, it's nice to see everyone. I have recognized a lot of your names coming through my email, so it's really great to put a face to the name and all of the research that I've been reading. So thank you all for joining us today. We've had such a dynamic discussion already, and we're starting to enter this territory of opioid use disorder, not just physical dependence, but actual meeting DSM criteria for OUD and chronic pain. And I just wanted to remind everyone that we recognize that to get to a actionable outcome, we need to recognize the whole patient. And so this specific session, we're just going to talk about OUD and chronic pain and acknowledging that these patients often present with other comorbid conditions. And so to make the science a little bit more digestible, we organized this day so that we're splitting session 2 and session 3 apart, just to make everything a little bit more focused. So I also want to remind everyone that the intent of this workshop is to come up with priorities for the next 5 years. So think about that when you're asking your questions, because a lot of the things that we're talking about it's going to take decades. And I love those comments, but we want to sharpen those priorities to the next 5 years. So we have 2 talks today. Please stick to the 15-minute timeline. Panelists will have 5 minutes, and then we'll open it up for discussion. Please type any clarifying questions and broader questions in the chat box. We'd like it to be a dynamic conversation, so we would prefer you not to necessarily respond in the chat box while we're having this ongoing conversation, because it might be a bit distracting to some of the participants. The questions will be captured, so presenters will have an opportunity to address them either offline in a separate private email to you, or during the breakout sessions that are happening on day 2. If you want to contribute to a response, please raise your hand. I've been seeing that function happening, so kudos to all of you for being Zoom wizards. And so with that, I will pivot to Barbara to kick us off for session 2.
Okay. Thank you for having me here today to talk with you about interventions for opioid use disorder and chronic pain. It's been evident over the years of my clinical practice as well as research that that there is a lack of studies on interventions when people experience the combination of chronic pain and opioid use disorder. Next slide, please. In a systematic review of pain severity and opioid craving in chronic pain and opioid use disorder, found that to evaluate measurement and association with pain severity and opioid craving, the difficulty lies in the heterogeneity of the measurements of opioid craving, which was just recently brought up in our day. There are a few tools that are used, but the definition is not clear, and the tools that have been used to define opioid craving have actually been extrapolated from other types of craving, whether it's alcohol or whether it's cocaine. So that is an area that needs some work on as well. And it's been found that with chronic pain that it is associated with a 3-fold higher odds of reporting craving in the past week, with greater significance in those with moderate to severe chronic pain. Next slide, please. So chronic pain patients on opioids with pain severity that was modestly associated with opioid craving. Patients with treated opioid use disorder who experience chronic pain may be vulnerable to opioid craving and thereby relapse. The increased opioid craving in the setting of chronic pain is a mechanism that leads to relapse. So chronic pain patients it's common for chronic pain patients to have opioid use disorder in addition, as well as opioid use disorder patients to have chronic pain and have that be intertwined with craving that is occurring. That just draws attention to that more research attention is needed for screening patients in chronic pain for opioid use disorder and screening patients in opioid use disorder treatments for chronic pain and screening them for that. Next slide, please. Leading to knowing more about chronic pain in the setting of opioid use disorder requires that we look at the evidence of chronic pain interventions. So I have here chronic pain guidelines that have been done and are published, but there is little about the use of these interventions in opioid use disorder. So I'll start out by talking about non-pharmacologic, non-interventional modalities, then non-opioid pharmacologic interventions, and then opioid interventions, and then I'd like to close with what patients are saying as the stakeholders here. Next slide, please. So the non-pharmacologic modalities that I'm drawing from are from a comparative effectiveness review through AHRQ. So regardless of the cause of pain, always consider that non-pharmacological interventions are preferred, especially in the context of a comprehensive plan for musculoskeletal pain and for chronic pain. But not all non-pharmacologic modality options have the same strength of evidence to support utility. Next slide, please. So I'm going to be using diagnoses that are consistent with this review, and the diagnoses are the most common chronic pain conditions that are chronic low back pain, chronic neck pain, osteoarthritis, fibromyalgia, and tension type headaches. Also in the review is a definition. Now, exercise has been used as a comparator in these studies, but exercise, when it's as an intervention that is being studied, is defined as muscle performance, mobility, muscle re-education, and aerobic exercise. Also in need of definition is some acronyms that I have on the slide. ST being short term, which is 1 to 6 months, intermediate term 6 to 12 months, long term greater than or equal to 12 months. And then to define insufficient or very low evidence is either unavailable or does not permit a conclusion. And low support of evidence, strength of evidence is low confidence in that evidence, and moderate strength of evidence is moderate confidence. So please, next slide. So exercise. So I'll be talking about the actual modalities to define where they've been applied in the studies, and looking at pain and function primarily. So in osteoarthritis, exercise has been used to improve pain and function in a small to intermediate effect with moderate strength of evidence. Chronic low back pain has improved function and pain with moderate and low strength of evidence, and respectively. Chronic neck pain exercise has improved function, but that has low strength of evidence. And fibromyalgia has improved function and pain with low and moderate strength of evidence, respectively. Next slide, please. Massage has helped people with chronic low back pain for their pain with moderate strength of evidence and function with moderate strength of evidence. And for individuals with chronic neck pain for pain and function with low strength of evidence for the short term. Acupuncture has helped people with chronic low back pain function improvement, but there's low strength of evidence for short-term and intermediate-term level of measurement. And then pain has improved with moderate strength of evidence with chronic low back pain in the short term with acupuncture. Chronic neck pain, when administered acupuncture, has improved function, and that has low strength of evidence for short-term and intermediate term. And then fibromyalgia has improved function with acupuncture with moderate strength of evidence. Can you do the next slide, please? Multidisciplinary rehabilitation, when patients have chronic low back pain, function and pain has improved with moderate strength of evidence for short-term and intermediate term. And fibromyalgia, function and pain has improved with low strength of evidence. And yoga, with chronic low back pain, function has improved with moderate strength of evidence in the short term, and pain has improved with low strength and moderate strength of evidence for short-term and intermediate term, respectively. Next slide, please. Spinal manipulation has shown pain moderately improved, but insufficient evidence for people with chronic tension headaches. Low back pain, function and pain has low and moderate strength of evidence for spinal manipulation helping. And then low-level laser therapy with chronic neck pain has improved pain and function for moderate strength of evidence, and chronic low back pain has improved with pain and function. And for those who don't know, low-level laser therapy is an alternative type of therapy that has laser light at low levels and near infrared light that's applied to the skin with the intention of decreasing pain or inflammation or promoting healing of wound and tissue and nerves. Cognitive behavioral therapy and mindfulness-based stress reduction and psychological therapies for chronic low back pain has moderate strength of evidence for the short term and low strength of evidence for the intermediate term. For fibromyalgia, pain and function has low strength of evidence with the use of cognitive behavioral therapy, mindfulness-based and psychological therapy. And then osteoarthritis has small improvement on pain and function with low strength of evidence. Next slide, please. The next guidelines are on non-opioid pharmacologic intervention, and I need to disclose that I was a peer reviewer on this. Next slide, please. I'm dividing it into diagnoses this time, starting with neuropathic pain, which shows small improvement in pain and function in the short term using SNRI antidepressants. No improvement in function with the gabapentinoids, and no clear effect, or I should say inconsistent evidence on pain, function, and quality of life with the use of capsaicin for neuropathic pain, cannabis, and amitriptyline for neuropathic pain. Next slide, please. Fibromyalgia on the next slide. Small improvement on pain in function and quality of life in the short term with SNRI antidepressants and the gabapentinoids, and then moderate improvement on pain, function, and quality of life in the intermediate term with memantine, duloxetine, and milnazepam. There's no clear evidence on pain, function, and quality of life for fibromyalgia in the intermediate term with amitriptyline or cyclobenzaprine. Next slide, please. The osteoarthritis, there's small improvement with pain and function with SNRIs, and I'd like to add to that as well non-steroidal anti-inflammatories, and no clear effect on pain and or function with acetaminophen. The low back pain, there is limited evidence, small improvement with pain and or function in the short term with SNRIs, and no improvement in function with duloxetine. Inflammatory arthritis, there's small improvement in pain and or function with non-steroidal anti-inflammatories. So I'd like to say overall, comparing drugs and dose did not identify differences, except diclofenac improved pain and function moderately more than celecoxib. And now the next slide. In looking at the adverse drug events, withdrawal from non-opioid pharmacologic treatments, there was a large increase in adverse drug effects to the gabapentinoids with blurred vision, cognitive effects, dizziness, weight gain, peripheral edema. And in the dose reduction was studied to reduce adverse drug events in SNRI antidepressants. Coronary events, there's small and moderate increases in short and long term with the nonsteroidal anti-inflammatories. So in conclusion, from these recommendations, there needs to be careful consideration of patient characteristics that are needed in selecting non-opioid drug treatment. Next slide, please. Regarding opioid treatment for chronic pain, the premise is that non-pharmacologic, non-opioid pharmacologic treatments are preferred in chronic pain for chronic pain treatment. The recommendations are to only add opioids if the benefit for pain and function are anticipated to outweigh the risk. Next slide, please. Even though opioids are still being prescribed at large levels, the outcomes indicate that there's no difference in opioids compared to non-opioids medication in improving pain, function, mental health, sleep, and depression, and little improvement with opioids or non-opioids combined for the improvement of pain. The risk for adverse drug events, when you compare opioids to placebo, they show GI effects, somnolence, dizziness, and pruritus. And of course, the co-prescribing of benzodiazepine and gabapentinoids increase the risk of overdose versus opioids alone. And I'd like to state here that from what we've talked about earlier today, that looking at these overdoses from the idea of potential suicide or self-directed violence needs to be looked at. Please address, or please have the next slide. Next, okay, thank you. Observational studies compare no opioid use and dose-dependent risk with increased risk of discontinuation compared to no opioid due to opioid overdose and dependent diagnosis, overdose all-cause mortality, and fractures and falls. And with those, there's no evidence of dose-dependent risk and myocardial infarct. There is no randomized controlled trials to evaluate intermediate or long-term benefits versus placebo. Next slide, please. There is a lack of evidence with opioid intervention, and that's no surprise to anyone presenting or present today, that the effectiveness and harms of alternating doses, really there's a lack of evidence for that. There's a lack of evidence for risk mitigation strategies, but we have talked today about naloxone, and that is an exception, has been shown to decrease emergency room visits. And then the benefits of harm, also there's benefits and harm with lack of evidence of opioid therapy for people at high risk for opioid use disorder. And then inconsistent evidence with diagnostic accuracy in various risk prediction instruments as well, and little evidence of differences between long-acting and short-acting opioids, though long-acting opioids have been associated with increased risk of overdose. Next slide, please. Buprenorphine and methadone outcome studies show no difference between methadone and buprenorphine on patients with opioid dependence due to prescription opioid for chronic pain, and that is with outcome measures of study retention, pain function, and urine toxicology. Long-term and low-dose methadone and buprenorphine naloxone treatments produce analgesia in participants with chronic pain and opioid addiction. Buprenorphine maintenance has better outcome than tapering with buprenorphine, and that's been shown with two studies in particular, though one study did screen out patients in pain and just looked at it from patients on opioids, and tapering with buprenorphine showed higher rates of urine toxicology that's positive, greater number of days or per week of illicit opioid use, fewer maximum consecutive weeks of abstinence, and less likely to complete the trial. The one study showing with pain patients with opioid use disorder with a taper of buprenorphine actually was stopped after after an N of 12 due to poor taper outcome. Though they did follow for 6 months, they followed patients who were on maintenance, and it showed improved pain outcome and function. Next slide, please. So while data tells a story, I do have some comments from patients because they are the ultimate stakeholders and have a story to tell. And this is taken from my research in a methadone clinic, as well as a primary care practice that was prescribing opioids for pain. Patients stated that there was confidence, that they had confidence in their healthcare team, then their outcomes are better when there was confidence that the healthcare team could treat both pain and addiction. In fact, one individual stated, when they care, meaning the healthcare provider care, I care. They cared about themselves. Many of the individuals in the methadone clinic stated that just because I'm an addict doesn't mean I don't have pain. So we do need to be addressing this concurrently. The best outcomes are when patients state when they have really good doctors that they're working with now who understand their addiction and understand that they need to control their pain as well. To have a supportive and caring relationship with their healthcare provider is important, as they state it is. And open and honest communication is important as they experience less stress. If they had more ability to cope with pain, even when pain intensity was high, when they had good relationships with their healthcare providers, open communication and understanding. And that's all I have. Thank you.
I see a clarifying question from AJ. It's when he says that the results that you presented seems to just represent 1 or 2 systematic reviews regarding chronic pain treatment effectiveness, which drew some criticism. How do you explain that multiple other systematic reviews have reached different conclusions?
So if I'm understanding your question, you were wondering why the one study was stopped short because of patients having difficulty with the reduction of the buprenorphine. Was that your question?
No, it was mainly on the review, the AHRQ review of all the different treatments. So for instance, the conclusions about tricyclics for neuropathic pain, that's sharply disputed because those actually show some of the biggest effect sizes we have for any neuropathic pain treatment. Also, the criticisms of SNRI for NEOA, same issue. Some of those treatments have shown very large and placebo-controlled trials. So I just put that out as just wondering, because you were fairly emphatic about what you said, which was very nice. It was a very nice presentation, but there is all other stuff out there. So.
Well, and being a clinician myself and using these medications, I know that I have had effect. I think what the references are regarding how the studies were conducted, what the N was, and the interpretation. So, these are the panels that were doing the review. I trust had that capability to decipher the studies and the different qualities of the studies, as well when I was a peer reviewer on the non-pharmacologic, on the non-opioid pharmacologic approaches that getting into, as I was reviewing, getting into the basic research and science that was involved was part of my role there.
I saw a question from Amy about MOUDs. I'm gonna just punt that for a minute because I think our next speaker is gonna touch on that. And then Stefan, I see you have a question as well, and I'm hoping that Barbara might be able to answer that question offline. We will be capturing all of these questions in the meeting notes following today's adjournment so that you'll have them as a reference. So, and if there's time to bring it up, Stefan, during the overall discussion, by all means. So let's go ahead and thanks, Barbara. Let's pivot over to Tony.
Thank you very much, Shelley. And Barbara, that was great. I especially like how you organize the non-pharmacologic treatments, then pharmacologic non-opioid, and then opioid. I think it's really important that we present those both clinically and to the layperson in those terms. And I think traditionally that hasn't been done. And I think that those presentations, the way it's presented, has an effect actually. So I'm going to be talking about medications used for opioid use disorder and how they may be managed or may be used to manage comorbid opioid use disorder and chronic pain. As you probably already know, there's not a lot of evidence. I hope I haven't given away anything to those of you who are being kept in suspense, but I'll go over what little there is in the literature. Next slide, please. And I do not have any disclosures. Next slide, please. So I think it's important to first think about what comes first, the chicken or the egg? Is does substance use disorder come before chronic non-cancer pain? Does chronic non-cancer pain come before substance use disorder? Does it matter which order they present in for treatment and underlying psychopathology? So as we all know, chronic non-cancer pain is common among patients treated for substance use disorder, and substance use disorder is common among those treated for chronic non-cancer pain. Among lifetime substance use disorder, lifetime chronic pain prevalence is very high, and vice versa as well. But the question is, or one question is, there a difference between those, and then is there a difference in optimal treatments? Next slide, please. So some theories are that substance use is a coping mechanism for pain-related symptoms, or on the flip side, that substance use leads to injuries which can cause chronic pain conditions. And I think what's probably more accepted nowadays is this diathesis stress model, and that there are some semi-dormant characteristics in individuals before the onset of chronic pain, which are activated and exacerbated by stress of that chronic condition, eventually resulting in the diagnosable psychopathology. So this really kind of suggests that you can't really separate one from the other, but they're very interrelated. Next slide, please. However, there are just several studies that I could find looking at what comes first. Does chronic pain come before substance use disorder, or vice versa? 2 out of the 3, now these are all just in patients with chronic lower back pain, and 2 out of the 3 show that the substance use disorder preceded the onset of chronic pain, and the 3rd showed that there was not a correlation between chronic pain versus the substance use disorder. And I think that these are interesting studies, but not necessarily definitive or tell us what to do for treatment. Next slide, please. Now, as we're all aware, there are only 3 medications which are approved for treating opioid use disorder: methadone, buprenorphine, and naltrexone. I'm going to go over what those treatment doses are, not because I don't think everybody doesn't already know that, but because what we do for patients with opioid use disorder and those with chronic pain and opioid use disorder are different. So next slide, please. So I'll just briefly, patients on methadone for opioid use disorder typically receive doses, once daily dosing. 80 to 100 milligrams has been shown to be more effective than lower doses, and the kind of typical range is in the 80 to 120 milligrams per day. Next slide, please. Buprenorphine, obviously, several different routes of administration. The final stabilization dose, which is different from the starting dose, it is quite varied, but the average dose is around 16 milligrams per day. Again, once daily dosing is most common for opioid use disorder. 25 milligrams per day is probably the most common maximum dose, and there are new formulations that have recently been approved. Next slide, please. And then naltrexone, which is the most common dose, is 50 milligrams per day, but can be given in a couple different forms. But obviously is an antagonist and does not have any intrinsic analgesic properties. Next slide, please. So managing patients with comorbid chronic non-cancer pain and opioid use disorder involves several different things, not just medications, which I'm not going to talk about, have already been presented by various people, and as we just saw, in the previous talk. But a multidisciplinary care team is very important. Step care models seem to be very effective. And then therapies, which again were just presented very nicely by Barbara, non-pharmacologic treatment, non-opioid pharmacologic treatment, and then medications that are used for opioid use disorder. But these, it's important not to focus on just the medications for opioid use disorder, the mu opioid agonist antagonists, and ignore those other things, just as Barbara was speaking about. Next slide, please. So there are some very nice pathways that have been presented for how to manage patients who have comorbid substance use disorder and chronic pain. This is from what is probably the best guide that I have found in the literature, that was published in 2012 by the Center for Substance Abuse Treatment, and it's managing chronic pain in adults with or in recovery from substance use disorder. And it's first, ensuring that chronic pain is not due to something that's correctable or life-threatening, and then looking at whether the patient has active addiction versus in recovery, and then walking down the pathway. But specifically now, I'm going to focus on the medications for opioid use disorder and what information is available about how to use those. So next slide, please. But I would just encourage people to take a look at that book if you have not already done so, because it's quite thorough. Non-opioid analgesics, again, just so we don't forget that there are other medications, as Barbara pointed out, there are other medications with evidence for efficacy for various types of chronic pain. And I won't go into them in any detail, as Barbara already did. Next slide, please. So again, just to highlight, there's very little data available. There's kind of shockingly little information available. There are a lot of guidelines that people use. It's clear that higher doses of buprenorphine or methadone are commonly required when patients have comorbid opioid use disorder and chronic pain, and shorter dosing intervals appear to be beneficial. For methadone, from BID, instead of Q-day BID all the way up to QID, BID typically in older patients. Buprenorphine most commonly is used TID when both. Naltrexone obviously not used, as it lacks analgesic properties. Other opioids, should be used with extreme caution, again, as Barbara pointed out, in patients with opioid use disorder and chronic pain. Next slide, please. These are really the only two studies or meta-analyses that are available that I could find in the literature. Buprenorphine, when used in patients with both opioid use disorder and chronic non-cancer pain, has a small mean effect size in patients with those two comorbidities. In patients without opioid use disorder, it has a larger effect size in patients with chronic pain. This was just published. It's not actually, the abstract is available, and I couldn't actually even get a hold of a PDF of the article. And then buprenorphine versus methadone therapy, both appear to improve chronic pain, but there's still a lot of questions about the optimal dosing, the optimal interval, what side effects and adverse events. Are there concerns about opioid use disorder relapse when the interval and doses are changed? And next slide. And also, I was trying to understand, are there medications in the pipeline that are not FDA approved but have been but are actively being studied? And there really are none that I am aware of or could locate, even with a fairly extensive literature search and web browsing search. Ibogaine is something that had a minimal amount of evidence for use as a potential agent in opioid addiction, but it's not FDA approved. It lacks data, and there were some serious concerns about some pretty serious side effects. So unfortunately, I wish I had more information to share about optimal dosing and intervals with these medications, but there's just not a lot of information available. So thank you very much.
Thanks, Tony. Amy, did that presentation answer your question about the various dosing regimens for OUD versus pain? And if not, please unmute yourself and ask.
No, it did. I was just curious with the studies that Barbara was reporting on when they were talking about pain and OUD, which regimen or how were they using that? So it was more about the studies that Barbara was reporting on than current regimens. Does that make sense?
Yeah, it does. And the dosing parameters, I just don't have off the top of my head on what they
Fair
were.
enough.
Were there any other clarifying questions for Tony? Otherwise, we will advance to our panelists. I'll give a few seconds because I know that people are typing them in real time. Okay. That was awkwardly enough silence, I think, right? Okay, so let's just go forward with our panel. We'll just go in order in presentation. So Mark, if you want to open, you have about 5 minutes to provide any thoughts and comments.
Sure. Thank you for the opportunity to comment. And these were two really terrific reviews of the literature, both succinct and thorough. A couple things stood out to me as I was looking through the slides and thinking about the literature on both chronic pain and opioid use disorders. And what struck me was that you could come to two somewhat different conclusions if you approach this topic from the standpoint of pain treatment or opioid use disorder treatment. So what I mean by that is on one hand, with chronic pain, there's really a robust literature describing the myriad of psychological factors underlying the development and persistence of chronic pain. And you have a large number of studies showing the efficacy of non-pharmacological pain management interventions among individuals with chronic pain. Yet, medications tend to be the most commonly used treatment for chronic pain, and in many cases, there's a preference on the part of both treatment providers and patients to have medications as the first line of treatment. That stands in contrast to the literature on opioid use disorders, where you see that there is a lot of evidence for the efficacy of medication-assisted therapy for opioid use disorders, or MAT for opioid use disorders. If you include the methadone literature, we've known for 30, 40 years that consistent dosing on methadone works to treat opioid use disorders. Yet the studies of non-pharmacological treatments for opioid use disorders tend to show very limited benefit. And actually, we really don't have strong evidence that additional adjunctive non-medication treatments for opioid use disorders improve opioid-related outcomes. But yet, when you look at what treatment providers and patients want, they often want to start with the non-pharmacological treatments for opioid use disorders and are reluctant to use medication treatment. So, it creates kind of a strange comparison when you think about those two different areas of literature that have grown up separately. And I think the challenge for us in the field is how do you fit those together and think about improving outcomes in individuals with both conditions. If you look at, as both speakers pointed out, we really have very little go on the literature in terms of integrated treatments for both substance use disorders and chronic pain. In my case, we've conducted 2 randomized trials of interventions for people who have kind of a grab bag of substance use disorders, not just opioid use disorders, and chronic pain. And what we found is some modest evidence for efficacy on pain and functional outcomes, and very little support for the idea that those interventions are improving substance-related outcomes. We did find that in one study, not in another. All of this, again, was not specific to opioid use disorder, but I think it means we have to be careful with our enthusiasm when we think about how to improve opioid use disorder treatment. So I know a number of us on this call have HEAL funding or projects that are currently underway to extend medication-assisted therapy for people who already have an opioid use disorder and chronic pain, and look at what the benefits of non-pharmacological treatments might be. And as much as, you know, as a psychologist and someone who believes in non-pharmacological treatments, I'm enthusiastic about that work. I think we also need to be realistic about the extent to which, at least historically, non-medication treatments have shown added benefit for people with opioid use disorders. And I think we need to be careful not to play into this narrative that somehow non-medication treatments are better or should be considered instead of medication treatments for opioid use disorders, because there's certainly a long history of that mindset in this country, and I think it some would argue has had really damaging effects for people who have opioid use disorders. So what, to maybe look at it in a little more positive light, what could be the benefits? What things are there to gain? I think patients in opioid use disorder treatment are eager to learn about pain, to have an honest dialogue about their pain. And so this creates an opportunity for treatment providers to really engage with patients, to talk honestly about what their pain, their realistic pain-related trajectories might be, to work on constructs like acceptance, different ways of conceptualizing pain, and encourage better behavioral coping with pain. I think it also opens the door to really reinforce the message about the importance of adherence to MAT, and encouraging patients to stay with their treatment and talk with their treatment provider about how they can better adhere to the treatment being offered. And you know, I think it's also important to use that as an opportunity to talk about what are the triggers for relapse and the ways in which pain might be a unique trigger or similar to other triggers in their lives that could lead to a relapse. I know in my own data, we haven't published these findings because they kind of go beyond what you typically see for you know, analyses of randomized control trial, but we see that patients tend to sort themselves into two groups: those patients who stay engaged in substance-related treatment and avoid using substances, and those patients tend to do better over time, not too surprisingly. And then there are those who relapse, and once someone relapses, you see a whole cascade of negative outcomes related to pain, functioning, mood, you know, pretty much everything, employment. And so really key to positive outcomes in that group is reinforcing the importance of staying in treatment, staying engaged. If there is a lapse, trying to re-engage as quickly as possible, and hopefully avoid more negative outcomes over the long run. And that's all I've got.
Thanks, Mark. Okay, let's move to Julie.
Yeah, I think I'm going to pick up and hopefully expand a bit on some of the things that Mark was talking about with respect to especially the role of non-pharmacologic and non-interventional treatments from a pain management perspective. And I think there was a comment in the chat as well about the evidence that was cited to support non-pharmacologic care in terms of its characterization with small effect sizes, and particularly when compared either head-to-head or versus a placebo. So one of the challenges with non-pharmacologic care for pain management is the small effect sizes, and the challenge with persistent or longer term benefit, probably for some of the same reasons that have just been mentioned with respect to adherence and engagement long-term for patients. But it is the case that patients seek out a variety of non-pharmacologic care, as was mentioned by an earlier speaker, oftentimes in the complementary or integrative space that's outside the healthcare system. And you know, this certainly indicates that there's a patient demand for care that is non-pharmacologic to deal with their pain issues, but that it's often necessary to seek it out in ways that aren't embraced within the traditional healthcare system. I think some of the challenges with respect to the research, and this has been mentioned as well, is there haven't been much work that's explicitly examined pain management strategies for subgroups that have OUD or who are currently within a tapering regimen, to really understand the interaction between non-pharmacologic efforts to provide pain relief that occur concurrently with medication or other efforts to manage an opioid use disorder. And I think this has also been hinted at, but I think it deserves some further discussion as well, that there are significant implementation challenges that surround the delivery of non-pharmacologic care, particularly for pain. And some of these have been mentioned, but payment models by and large don't support the availability of this care as well as medication in most instances. There's significant challenges that create health disparities in low resource communities, rural communities, about either the availability of providers for non-pharmacologic care or just community resources in general that support self-management as a lifestyle. There's a significant educational need for providers of non-pharmacologic care to better understand the pathophysiologic nature of addiction. Speaking as a physical therapist, I can say this is something that we're not, as a profession, nearly as well trained in as what would be really demanded of in the current situation. There's opportunities, given the amount of non-pharmacologic care sought by individuals with chronic pain who may either be or be moving towards an OUD for screening, and again, that's an educational opportunity that's missed. I think there's some positive examples to look to, most notably, at least in my mind, the Whole Health Initiative with the VA, which has, I think, created some unique ways to overcome some of these challenges, to make non-pharmacologic care not only available, but part of the culture of care broadly within the system. And I think there's some benefits that are being recognized there. And you know, the one other thing I think, maybe this is just because this is so much on my mind as someone who does research in these types of treatments, that these are generally literally high-touch treatments. So the impact of transitioning very rapidly to remote and non-face-to-face delivery for things like patients who are receiving acupuncture, massage, or physical therapy or chiropractic care obviously presents some unique challenges that we just have very, very limited research to examine how to best deliver care that comes from these kinds of disciplines in an environment that may be with us for a while, as one among many challenges to delivering effective treatment. And then I'll just finish by offering up that I think there's also in sort of the largely non-pharmacologic space a lot of opportunity that's also been mentioned for public health or population-based strategies that really would be directed at changing attitudes towards pain, towards opioid use, and towards individuals with opioid use disorders that would potentially be very beneficial in reducing stigma and changing both provider and patient perspectives on pain management.
Thanks, Julie. Ingrid?
Well, I was going to focus my comments less on sort of specific approaches of medications and non-pharmacologic approaches to treating both pain and opioid use disorder, but more on the context and the environment that might influence whether those medications can be delivered in a safe and an effective way in practice. And I think this touches on some of the things that have been brought up in the prior panel as well. I've worked both in primary care settings and in methadone and in buprenorphine type clinics. And my concerns about this context in which we deliver the care to these patients with both conditions really come up in both settings, but I'll use the example predominantly from primary care. So we've conducted interviews with patients who've been prescribed opioids at some point, not necessarily chronic opioid therapy, and experienced an overdose. And these patients who had an overdose predominantly have had pain. They predominantly had prior trauma. They have substantial psychological distress, which I know we'll be discussing a little bit more in the next panel. And a number of them, most of them also meet criteria for substance use disorder, at least at some point in their lives. And while some of the overdoses occurred from the prescribed medications, many of them occurred from other medications that they were receiving or taking, or substances that they were using to try to manage their pain. And one of the major themes that came from these interviews is that patient thought that their providers were not necessarily acting in their best interests when they were caring for them. And that this actually exacerbated potential safety issues and effectiveness in their management. And so these were patients who overdosed, and they basically felt like their providers, both in various settings, were responding to mandates that sort of came from above, but weren't necessarily in their own best interest, in the best interest of the patients. So these were things like guidelines and policies and monitoring, PD&P checking, urine toxicology, frequent visits, even if they were stable in recovery or stable on treatment. There were just a whole series of things that they felt that providers were doing more because they were being told to do those from above, rather than necessarily because they were really serving the patient well. So I think one of the issues with some of the medications some of the treatments that we provide is that they're not necessarily being provided in the best context or the best patient-provider relationship. And let me just give an example that came up in one of our interviews. So patients had this concept that we call, or this perception that we call dual loyalty that providers had dual loyalty in our interviews. And what happened is that they often would describe things like, these are patients who'd overdosed, would describe things like they tread very lightly in describing their pain to their providers because they're worried that they're going to be seen as drug seekers. Or they tread lightly at describing their risk behaviors because they don't want to be perceived of as addicts. And they know that these things may have consequences on their pain treatment. And they had tremendous anxiety and actually fear as a result. And one of the things that happened is that then they would have uncontrolled pain because they wouldn't even really get the opportunity to be offered potential treatments because the providers didn't necessarily know that they had uncontrolled pain because they weren't revealing those things. Or they also wouldn't be describing their risk behaviors, such as using alcohol or sort of stockpiling medications for a rainy day when they might not have access. They couldn't really discuss those things with their providers. And so they never even had the opportunity to have a conversation with their providers about how to reduce their risk behavior, whether to have naloxone around, how they could adjust their medications or their behaviors to be safer. So this really impacted both effectiveness and safety. So I think one of the things, one of the consequences that people took matters sort of into their own hands. They would use alcohol with their opiates or with their buprenorphine and try to address their pain their own way. And of course, this was a select group of patients. I think we do a much better job, hopefully, with most of our patients than these guys, because these were individuals who'd had an overdose. But I think there's some lessons learned there potentially about the context of treating both opioid use disorder and pain. So my hope is that sort of the medical profession, that patients don't feel like that we as providers don't have dual loyalty, and that potentially we could really try to find ways to communicate better with patients, that we have their best interests at heart, that their pain is validated and addressed, and that they're not going to be penalized for risk-taking behaviors that they then disclose to their providers, and that their providers are actually not doing things just because of policy and just because of laws, and just because of sort of clinical guidelines and mandates, but they're doing it in the best interest for their patient. And I think then we may be able to actually get more effectiveness and more safety out of the medications we have available to us. So those are my thoughts.
Thanks, Ingrid. I've seen a lot of questions coming in the chat about implementation, and we heard from Stefan this morning about de-implementation, and now, of course, there are things that we want to widely implement. I do want to clarify, NIDA has a huge portfolio and have dedicated lots of funding towards implementation questions around MOUD. Part of the reason why I asked Dr. Williams to speak this morning is to talk about this cascade of care and how there's a failure of de-implementation in our healthcare system. The point of today is to talk about how do we address both OUD and chronic pain, if that is with MOUDs or alternate therapies. So I just wanted to clarify that because I saw a lot of comments in the chat box, and I completely agree with you that that's a big issue for our field. I want to take this moment to pause because Lynn is our facilitator, and so I want to check in with you to see, you had some questions that you wanted to ask. I didn't know if there was some overarching themes you want us to start the discussion with, or I've also asked panel members to propose questions to ask the group that I think are important to discuss. So I want to check in with you first to see how you want to tag team the session.
Yeah, thanks, Shelley. I think that I wish we had twice the amount of time for these, because these are really good questions. I would maybe suggest posing some of the overarching questions that you had identified, because I think they capture a lot of what folks have brought up and are, you know, as you say, have a lot to do with this dual focus and thinking about treatment and next 5 years and sort of where we can get. So maybe to just put a few of those out and see if people have comments that are informed by the presentations we've had. So
I think that there's a few that were brought up, and so let me ask the two questions, and maybe we can poll the audience on which one you want to address, because I think right now there's so much content, it's hard to dive deep. So I'd rather spend some time diving deep into one area rather than sort of at the surface. So the two questions that I thought programmatically was really important to address. One is sort of this issue that Ingrid brought up about how do we foster a better relationship between provider and patient with regard to managing both conditions? How do we foster this honest conversation that doesn't penalize the patient? And then the second question that I think is really important is, and this follows up on Tony's presentation, for patients with OUD managed on medications for opioid use disorder and they have chronic non-cancer pain, when should the MOUD dose and interval remain unadjusted, and when should they be maintained with other therapies? You know, and what are the net benefit and risk to adjusting that dose or that interval? So they're two very different questions, but I think really important that extend beyond just this session, and that can apply to other sessions as well. So maybe for folks who are on video, do you want to put up a finger of 1 versus 2, like the first question versus the second question that you want to discuss? Joanna, I see 1. Okay, the ones Eric is scratching his beard and I think is a 1. Okay, let's go with question 1, which again, I'll repeat, is how do we foster a better relationship between the patient and the healthcare provider? I will also mention that we do have a representative from PCORI online, and so if Layla, if you wanted to jump in and kind of talk about from your funding agency's perspective some of the gold standards that you've seen, by all means. But I want to listen and I want you guys to talk.
Just a very quick
note. Sorry, Eric, go ahead.
I'm just going to say just a very quick note. I picked 1 because I don't know if we can say anything about number 2 at all, because we have no data on that, right?
Right.
We'd be literally just making it up. I mean, I guess it would be clinical practice wisdom, but Just a note.
So I picked one because when I did my study at the methadone clinic in Minneapolis, that's exactly what patients stated or the participants stated, was that they wanted to make sure someone had their back. They wanted someone taking care of them who would be their advocate. And that was when they felt less stress over having pain and opioid use disorder.
Yeah, I was going to go back to the talks this morning on stigma and how many providers have so much stigma towards addiction. And welcoming Valerie, he just showed video to chime in here too. But I mean, one thing that we see in our work is patients have been treated horribly by providers and have a lot of mistrust of providers. And so how can we work to actually train providers better to have more compassion for patient experience? And how can we train providers to have less stigma of both addiction and pain? So that's what I think is really a huge research priority for going forward.
I'll just, go ahead.
So this is John Farrer. I just was going to say that first, the provider has to want to change. And I would argue that one of the biggest problems is the current structure of care in the United States and the lack of emphasis on mental health care, which is really what we're talking about here, is taking care of the patient's stress and anxiety as a way of communicating. And in the situation where you've got 10 or 15 minutes max per patient, it's very, very hard. So I completely agree that we ought to take better care of these folks and pay attention to them and show them respect and when necessary, be honest with them about why we're being harder on them in terms of how frequently they have to come visit or when we're controlling their medicines more than we might with other folks. But it's a really difficult issue, and while I agree that resources that demonstrate that would be beneficial might help to influence the way in which these things are provided, I will admit to remaining a skeptic in the current environment.
Well, I would say in addition to training providers, we also need to think about teams and other people who can support patients, whether it's other staff in the office or counselors or family members or peer navigators, right? So we know we can't rely on physicians to always do a good job at communicating with patients. So we also need to look elsewhere. But I think just to come back to Ingrid's point about the context, I do think that's so important, and it is because we have siloed care, right? So in the OTPs, where someone's opioid use disorder may be being addressed, there's not always a primary care provider to manage the pain, and so it is. I understand this tension that it can create with the addiction provider also treating the pain that I'm not sure that we're going to solve by training that provider better.
And I should just add really quickly that when I said provider, I meant broadly. So that includes nurses and care managers and other people who can be involved in patient care, not just physicians.
Just to add a slightly different way of synthesizing this. So one thing that I think I'm hearing is people talking about opioid misuse behaviors. And we talked a little while ago about nomenclature, but we have a nomenclature problem, I think, with this as well, right? So it's basically, people who are on long-term opioid therapy who are having some kind of struggle while they're on this long-term opioid therapy. And there are lots of these that have been described in the literature, but how does one, including concurrent alcohol or other substance use, including having multiple prescribers, running out early, behavior towards staff that might be angry or aggressive. So I think one other way to kind of frame some of this is what are the strategies that not only individual clinicians, but also, as Joanna said, that teams or systems can use to help systematically assess and manage opioid misuse behaviors. And so Joanna and I and a group of our colleagues have done some work in this space trying to understand what best practices are for assessing and managing misuse behaviors, but they include a lot of systems level support and things like EHR, support for identifying and responding to behaviors, et cetera. So happy to talk a little bit more about some of the things we found, but just to say that, yeah, I agree that it's hard to change provider behavior, but there are ways to maybe include some supports at the systems level as well.
Stefan, you've had your hand raised.
Yeah, thank you. So two things come to mind here. One is that in our study of Veterans Affairs homeless patient aligned care teams, we actually compare 26 different clinics organizationally in terms of how they operate by interviewing and surveying the staff. And then simultaneously, we are comparing patient experiences. And one of the most negative and common patient experiences is the perception that the people caring for them are not cooperating with one another. In that perception of whether there is cooperation among members of the clinic is itself driven in part by features of how clinics are actually set up in terms of the number of personnel, the number of auxiliary personnel in those clinics, the teamness, if you will, of the people who are in that clinic in terms of how they feel about each other. So in terms of providing patients a sense that there's a collaborative team working with them, that seems to be something that's amenable to alteration by management, based in part by who they select to work with the most vulnerable patients, whether they equip them with additional resources to serve those patients, including tangible supports that they may need. We heard that earlier. And the kinds of mutual relationships that are fostered between the people on the team. And these things are measurable, they're implementable, and they correlate with aspects of patient experience. We're just writing up this result now. The other thing I want to highlight, it relates to something Dr. Binswanger said, which had to do with the patient's perception of a dual loyalty, or a clinician who's subject to dual agency is the term used in the ethics literature. We have a paper on that coming out in about a month. I do see this in the chart all the time, and I think we have a problem in how we socialize and train medical professionals especially, but sometimes allied health professionals too, in which they are led to see themselves as operating on a different plane from the people they're supposed to assist, and then have trouble engaging with patients as an equal. And there is a lot of work on this done by a colleague and friend of mine who's been funded by VA Health Services Research to study medical decision-making, which the visits are actually recorded. And he has some work in planning phase now to record visits in which opioid management is recorded. And these are often when the provider doesn't know they're being recorded at that visit, although they know they will be recording. And there are characteristics of interaction in which there's a successful negotiation and identification of what matters to that patient. And there's characteristics of interactions where the clinician just blows right by what that is. And it seems to me that we can address some of that in the training phase. Yes, I want longer visits with my patients, but some of this has to do with how we socialize the medical profession. And I think we can address it. Thank you.
So I see that both Ingrid and Kathy have their hands up. Maybe if you have a response to Stefan first, and then to speak about your issue, that'd be great. Ingrid?
Sure. So, I was going to mention that, one of the other questions that comes into place is who is the best provider to manage these patients? I mean, we obviously team-based approaches are the best, but ultimately somebody needs to take responsibility, because there's a lot of trading of patients, oh, I don't want to manage this patient in primary care, they're too complex, I'm going to shift them over to addiction. Then we have a bunch of low-risk patients in addiction treatment that are using up valuable spots where it should be higher risk, probably patients. And then we have, pain specialists who might not manage opioids. So there's a lot of do we need a new specialty? I guess I'm even unclear on who is trained to actually manage both pain and OUD, and do we even have the appropriate specialties right now to do this? So that's just sort of another issue about the team.
So, and I think one of the things that Stefan mentioned in the course of talking about that was the coordination and collaboration of care. And I'm wondering too about, given what others are saying is the predominant treatment model of these folks getting treated in primary care, can we bring what we know about collaborative care in mental health disorders in to meet some of that need? So Kathy, I don't know if that's what you wanted to comment about, but maybe you can comment about that as well. You're muted still.
And let me know if I break up. I'll try to talk slowly. I wanted to build on the teams concept because I think it's going to take teams, and I wanted to talk a little bit about our experience in Kaiser Washington, where we had a health system that really honestly didn't address addiction, didn't address mental health integrated. And care was contracted out to the external environment for addictions. And we implemented, the piece I want to say, the take home is that with teams, we need systematic measurement. And what we did was systematic population-based measurement where people with high risk use of alcohol, cannabis, or drugs got a symptom checklist of the DSM-5 criteria. And we did that as a conversation starter. So this whole notion of communication between a provider who may not know much about addiction and a patient, we taught them to say, oh, you said you'd been craving, tell me about that. You tried to cut down and been unable, tell me about that. So we focused on the conversation. And so standardized measurement, teeing up the conversation and seeing this honestly, I think it's a 10-year workforce development challenge. And then the third, which is very critical, I think, is that whole trust problem. And this part we addressed very head on with language. And I think we have to get words like misuse, abuse, addict out of our language and start trying to use as much destigmatized language as we can. The other thing that actually Lynn and I found when because we're starting up a trial in this niche, was talking to people at the VA. And I think one thing we learned from a social worker there was that the tapering that has gone on, certainly in the VA, where it's a more top-down sometimes, tapering has really breached that trust. So you already had a communication problem and a trust problem and a coordination of care problem. And then you threw this amazing wrench into the works, which breached the trust. And frankly, the patient and the provider were traumatized by that. And so I actually think we need to think about that we actually do have a traumatized patient and provider workforce. People were told, treat pain, get rid of the pain, give them opioids for a decade, and then all of a sudden, like, no, stop. And so I think it's a very complicated territory, but I'm excited about this initiative because I think we need to jump in and deal with real systems and real patients. I'll stop there.
AJ had messaged me that he couldn't raise his hand, so I'm raising it for you.
Great.
Okay, thanks. I was just a question, just because I was thinking about something, but I didn't have a thought, but then I couldn't say it because I couldn't raise my hand. So it was just a clarification. How do you raise your hand? That's it. Thanks.
Okay.
Since I had that problem, it's blue at the bottom of the chat box.
Yeah, or also if you scroll down the participant list, you should find a hand that you can raise as well.
I just raised my hand, but I'll just speak about, coming back to the original question about how do we improve the relationship between the provider and the patient, and what kind of qualities or training is needed to facilitate that. I think we need to consider that too often there's sort of the black and white view of, is this a quote drug seeking patient or not? And so that totally obscures the complexities that are involved. For example, if a patient comes and reports, I need more opioids, why do they need more opioids? Is it an increase in physical pain? Is it an increase in emotional pain? Is the patient developing an appetitive response to the opioid, irrespective of their level of pain? And does the physician or the provider have the training and the biopsychosocial framework necessary in order to parse out those three different pathways Or I'd actually add the fourth pathway that I mentioned earlier, which is with regard to emotional pain. Is it a surplus of negative emotion, or is it a deficit of positive emotion? Or, are they lacking a sense of reward, meaning, and purpose in their life that's also driving them to take opioids to fill the hole? So that now there you have 4 different pathways, and those don't even count the myriad of psychosocial challenges that these patients face, that they may kind of their minds and brains may interpolate as quote unquote pain, but it's really the quote unquote pain of having no job, of being overwhelmed in their families, of being in an abusive household, or being in a dysfunctional society that's burning every night on the news.
So I have conflicting hands. Robert, you're asking about pathways of pain and OUD, which kind of touches and follows up on what Eric was just saying, but Valerie has also been patiently waiting. So she's saying, okay, Robert, you go next, and then we'll go to Valerie. Okay.
Okay. Yeah, so I brought this up in other public settings. I do.
Robert, we can't really hear you very. Can you get closer?
Maybe.
That's better.
Better?
Yeah, it's better.
Get it off my lap. I think there are many different ways people with pain end up having OUD, but one of the ones that seems to be particularly relevant here is a pathway through prescribed opioids to misuse of prescription opioids, to beginning illicit use of opioids and so forth. And that contrasts with people that develop OUD outside, really without any particular interaction with the healthcare system. And I do think, in the context of thinking about the optimal person or setting who will be involved in care, that these differences really can be important to take into consideration. I use the term iatrogenic OUD, not to be offensive to my prescriber colleagues, but I do think that it gets to the root of, for many people, the experience of stigma and the way that people are treated, and the failure of the healthcare system, particularly prescribers, to accept responsibility for their contribution.
Valerie?
I just wanted to mention that there's been nice progress for stigma reduction interventions for healthcare providers, teams more generally in the field of HIV, and I think that some of those strategies could be adapted in these settings. And a lot of those, there's more and more movement to making sure that those interventions are intersectional in nature. So, there's been some comments, specifically speaking to making sure we account for race, for example, in these interventions. So Laura Nyblade is someone who does a lot of work in that area. I think that's a great resource. When I think about the different tools, that we have in our toolkit, one thing that's kind of sparking in my mind that is resonating with what some folks are mentioning is just the idea of behavioral design. So, especially thinking back to, if we have 5 years, where can we make an impact? Or stigma is big and it's hard to change. And it is correct that it's hard to change, some people's prejudice, people's hearts and mind in a short amount of time. Behavioral design is this idea, that if you standardize interactions to some extent, which I know that there's, pros and cons to that, but if you can try to constrain people's opportunities to act in discriminatory ways, that could be helpful. There's a nice book from the gender area called What Works? Gender Equality by Design, which talks about some of this, but I think that's a strategy that that might be useful to think about here in particular. And I also think, if we're thinking about what can we do in 5 years, focusing on trying to chip away at stigma from providers is a really nice target because it's, you know, it's something that might be changeable. We have examples of it changing from other fields, and it's also, you know, we've got good evidence that it's quite, or we have evidence from other fields at least, that it's quite harmful. So to me, when I'm thinking about stigma interventions, and stigma is so large, I really try to think about, well, what's the, you know, short and long term, and where should we be targeting? So I just want to highlight this as kind of a nice area, potentially a focus for that shorter term 5-year plan.
So I wanted to kind of go back to this question about pathways, because I've heard it being raised by Eric, by Robert, and also in Tony's presentation that there are different pathways by which people might arise at comorbid OUD and pain. I wonder how much of that actually matters. So in other words, do we need to develop unique interventions for people who have pain first and then use prescription opioids, legitimately become dependent, and they, you know, are undergoing forced taper, and then you might start seeing aberrant behaviors appear that otherwise wouldn't because they had a steady supply? There are people who we know are chronically exposed to opioids. Their brain undergoes significant neuroadaptations where they're no longer hyperalgesic. So I don't know if we know the answer. I guess my question to you, as all the experts in the field, is that one, do you hypothesize that that's something that should be further explored, that we need to delineate by pathways, or is it more just that we need better interventions to address both conditions or integrated care? What are your thoughts?
So I can address that.
I see Katie. Oh, go ahead. Katie, do you have it? AJ, go ahead.
Okay, so I do think that there is some qualitative data out there on that issue when patients describing their trajectories of how they developed an OUD, whether it started with pain or whether it was not related to pain. And certainly, you know, patients of on both sides of those issues, whether they had pain or not, will make that distinction themselves and describe that either the pain is the key issue that started, or it was, you know, just other types of risky behavior that maybe started their path of OUD. So I do think that there is some information on it, and I actually think it's a pretty critical decision because of all of the separate disease processes that are involved in having chronic pain. So that would be my view.
I don't know who raised their hand next. So
I would follow up with what AJ said, and I think the patients have differentiated. I don't know if we actually have evidence that once they're in the pain and OUD cycle that they're actually that different. But the patients, we've gotten a lot of feedback from individual patients, and this goes back to the stigma conversation that we were having a little bit earlier, that patients that come in with prescription OUD first are like, well, I'm not like them. They're different. They did something else. I don't want to be in a group with them, blah, blah, blah. So if you create different groups, you end up finding they're talking the same themes, they're saying the same things, they're doing it, but patients have the stigma of I'm not like that, and that's where you end up getting a differentiation, not so much in what the treatment approach is or how you treat them, as much as it's the stigma itself behind that.
So I'm actually seeing from our contractor who's coming in order. So Katie, you were next.
Okay, great. Thanks, Amy. I think, you know, first of all, there's 2,048 ways to have an opioid use disorder. So we should remember that addiction in and of itself is incredibly heterogeneous, and then you add in pain and you increase that complexity. And of course, it's not just OUD and pain, it's also PTSD and various other disadvantages that just make it incredibly difficult for folks. So I think one thing that's really important is to look at function. And so what is the function of the opioids in the person's life, and how is it functioning? And like Eric has said, both looking at negative affect, but also positive affect, as well as trauma, as well as sleep, as well as all the other comorbid conditions that people are medicating and attempting to medicate with opioids. And so we really need to, I think, look at patient-centered care, measurement-based care as directions forward, and that it's unlikely that you're going to find a particular treatment based on one specific pathway versus another specific pathway, and that each patient is going to require kind of that patient-centered and measurement-based approach to their treatment, collaboratively with their provider, going back to Stefan's point about medical decision-making and how important it is to have a collaborative approach with patients. And I'll be there.
Eric, you're next.
Yeah, I really appreciate what Katie said, and although I agree that probably if we took a fine-grained precision medicine approach, we would see that interventions that were individually tailored to that patient's pathway, it might make a difference in efficacy. The clinical trials that we do, it's just basically, it's the mean, right? It's the mean effect, and when you look at the raw mean effect, at least with regard to the mindfulness intervention that I've been studying for the past 10 years, I mean, it looks like you can throw in a grab bag of patients with different pathways and get an overall mean result, even though they're coming from very different places. And that's why I also appreciated what Amy said. I think I don't know if the sets of techniques need to be that different for different pools of patients, given that the common features are, high pain, craving, and maybe and then the negative affect, dearth of positive affect feature. But to the patients it matters, because as Amy said, the stigma is so great. Patients may not be willing to even entertain the fact that they do experience craving, which does lead to an underestimate of the report of craving. They don't even want to talk about it because they don't want to be viewed as a quote drug seeker. They say, hey, I'm here just for my pain. So I think from a motivational interviewing perspective, we need to engage patients differently depending on what their motivation for seeking help is. And then maybe once they're into treatment, it may be that there's a common set of transdiagnostic processes that are therapeutic for a range of different problems.
Kathy.
A lot of what I was thinking Katie said much more eloquently, but I'll add a couple things, which is that the severity of addiction, we really talk a lot of binary, and just to flesh that out a little bit, the severity matters, but also the other substance use disorders that are being treated matter. And from a clinical perspective, I believe that distinction is a cultural distinction that comes related to stigma, frankly, and it's class related. And in terms of the pathway. So I think it's one where we don't want to bake it into the treatment. However, engagement, we have to make as many doors that people can get into treatment as possible. And so there are different doors that people come into treatment, but I would distinguish that engagement piece from the treatment itself and the condition itself.
Stefan. Is it Stefan or Stefan? I don't know if I'm saying your name. I apologize if I'm saying it incorrectly.
Both.
Okay.
This is to Bob Kearns' question about the pathways to opioid use disorder. And I think that I'm not, if one thinks in terms of disease pathology and types of disease, we make distinctions based on tissue, and we often vary treatment based on a specific tissue pathology. I don't think a typology of how opioid use disorder operates in the same way. But where I think that the pathway matters a lot and could be measured in research is whether the assessment of an individual allows the patient and clinician to develop a shared narrative of how did we get to where we are. And it could be that it is very important for the patient to hear that there was an intersection between what clinicians did 5 years ago and what that patient was doing to cope with childhood sexual abuse or something like that, and that the two came together in a very harmful way and led to a horrific relationship with prescription drugs. But I think it matters a lot from the standpoint of narrative development. And it's hard to measure whether narrative development is helpful in care, but one can use survey and one can use qualitative research to assess the degree of concordance and the degree to which individuals feel heard, and then assess if that is associated with implementing a better care pathway or with helping a patient reach a better care objective.
Jessica, you had your hand raised and then you lowered it, so I don't know if your comment was already captured.
I kind of, thanks for noticing. I was ambivalent about my hand raised, but I guess, and I sort of said this in the comment in the chat box, but you know, the degree to which we have treatment available for opioid use disorder is so poor in this country that I almost feel like that's kind of first things first. We really need to do better implementation work to try to understand how to get evidence-based MOUD and also pain treatments to people who need it. And then I think these are all really important questions about how to do, whether you want to call it adaptation or some degree of precision medicine. I think that's all really important. But until we have, for example, buprenorphine access, you know, like if you can prescribe oxycodone, you can prescribe buprenorphine, and that's the norm. I think some of these issues are secondary.
Okay. Was that all? You look like you had more to say.
Yeah, that's it.
Okay.
That's all.
So we are supposed to end at 3:30, and I want to be mindful of everyone's bladders, but also this very dynamic conversation we're having. And so I know Ingrid and Barbara had their hand raised. Do we want to just hold on for a few minutes? And Robert, you did too as well, and then you lowered. So I don't know if you want to comment, but are we okay going for 5 more minutes? Yes? No one's leaving to run to the bathroom. I mean, I really have to go, but I can hold it.
I could talk about this for days, so if not longer. So
Ingrid, you were next. Why don't we go to you and then we'll go to Barbara.
Well, I was just going to ask the group, because I'd love to hear more, and maybe it's for another time, but you know, about all of these things that we do to, and I know Joanna's an expert in this, but you know, all these things we do to reduce risk and these risk mitigation approaches we have, and all the guardrails we put on our patients who have addiction and pain. And I'm just wondering, does this group feel that those, or is one of the areas that we need to investigate is the extent to which those things increase stigma and may worsen outcomes versus improve outcomes by providing structure and some kind of psychological benefit? I'm not sure, you know, and so I guess that's one of the things is how do we weigh sort of the risks and the harms of those kind of guardrails we place on patients that lead to some of this kind of sense that they have that they're being policed by their providers. I don't think we're going to answer that in a minute.
Barbara, I don't think your response is going to be to Ingrid's question, but I didn't know if you wanted to, had your hand raised.
Yeah, well, I can always talk. So, you know, I want to go back to who's responsible for these patients, because, you know, some of the comments were around creating a specialty or that there are specialists on there. And I just want to bring up access to care because there's so few. So if we were to look at who's responsible, I would head back into primary care and say, you know, that's the highest volume of the workforce. Another would be to plug into an even higher workforce, and that's nurses, educating the workforce. So looking at it from a nurse's perspective, when I'm seeing a patient as a nurse practitioner, I'm seeing them and then I might not see them for 2 weeks, but there's stuff happening in between the encounters that I worry about as a healthcare provider. And I really appreciate my care coordinator to be calling on my higher risk patients to just be checking in and making sure that, you know, they know what the treatment plan is, making sure they know what the resources are. So in terms of responsibility to manage patients with pain and OUD, I think we have to look at how can that access is going to be an important domain to think about to make sure that we've covered that very well. So another thing I want to talk about is pathway. So my qualitative research was actually my dissertation, and it was asking the question about how did people get there to the methadone clinic with pain. And in one of the publications, I actually tracked the trajectory to see when pain came first and then OUD, or when OUD came first and pain. And I hadn't thought of it from the perspective of, would you think about different treatments at that front end of both of those trajectories? And I think that that would be important. But the other thing to think about, by the time people got to a methadone clinic, it looked the same. So that was also something that, you know, when I heard Bob, you said, well, you know, there's stigma back here, and people say, no, that will never be me, or I didn't grow up wanting to be a drug addict, or, you know, those types of things that they'll say about themselves. When they get over here to treatment, it's pretty much defined for them. So that's something to think about. And then the third thing is, Ingrid, when you talked about reducing risk, things that we can do to reduce risk. I'm thinking, you know, back when we were treating AIDS, you know, we developed universal precautions. Is there something that we can develop that will support our healthcare providers in terms of universal precautions?
Okay, we're about 5 minutes over. Our next session, which will be the last one of the day, is 2 hours long. So I feel like people might need a little bit of a break. I'm really sorry to cut you off, Joanna, because your hand is still raised. But I know you know Ingrid, so you guys can always chat offline. Keep in mind that there will be time to flesh out these ideas more in the breakout sessions tomorrow, and hopefully ongoing conversations after this workshop. So I don't want the creativity to stop just because we have to have a potty break. So we're going to take a break now, and we should reconvene at 4. And I don't think you need to sign out. You can just stay on and turn off your video. And so we'll see you guys back here at 4 o'clock.